the third topic, that is vulvovaginal candidiasis, which is very commonly encountered in OPD practice. It is caused, 90% of the cases are caused by Candida albicans. 75% women at least have one episode of VVC throughout their lifetime. 40 to 45% may have more than equal to 2 episodes. What are the symptoms? Symptoms of vulvovaginal candidiasis are usually non-specific. They have external dysuria, vulval pruritus, vulvovaginal pain, swelling or redness. On a per speculum examination, there is a thick curdy discharge which is very characteristic of VVC. What are the risk factors? Wherever there is any kind of dysbiosis. What is dysbiosis? That is alteration of the normal microbioflora of the vagina and superimposed infection. It leads to vulvovaginal candidiasis. So, what are the certain conditions? That is uncontrolled diabetes mellitus, any kind of a debilitating illness, immunocompromised status or HIV, prolonged steroid use, pregnancy, obesity, and prolonged broad-spectrum antibiotic use. What is an uncomplicated VVC? Sporadic or infrequent, mild to moderate, likely C. albicans and non-immunocompromised patient. Whereas a complicated VVC is where there are several or recurrent episodes. How do you define recurrent VVC? Which is more than equal to 3 episodes per year, and the causative organism can be anything other than non-Candida albicans. Now, how do we diagnose this VVC? Where the vaginal pH is less than 4.5. That is, the vaginal pH does not change. The previous 2 STIs that we have studied, bacterial vaginosis and trichomoniasis, the bacterial pH increased. However, in VVC, that is candidiasis, bacterial pH, vaginal pH does not change. On wet mount saline KOH, we can diagnose this by seeing the hyphae of the fungus. Culture is the gold standard, whereas it is not usually recommended. Now, what is the basic treatment is? We can use clotrimazole 1% cream, 5 grams intravaginally daily for 1 to 2 weeks. Clotrimazole 2% cream, which is given for 3 days, or second option is miconazole creams 2%, 4% strength, which are available again 7 days and 3 days, or miconazole 100 milligram vaginal suppository for 7 days, for 7 nights usually we recommend. So, how do we recommend these drugs to the patient is? We ask them to void urine before taking these, dap the vulva dry with a clean cloth, and then use these kind of vaginal pessaries so that they stay overnight in the vagina. Now, how do you treat severe vulvovaginal candidiasis? That is, topical azoles can be given for 7 to 14 days, or you may have to add a fluconazole 150 milligram, 2 doses given 72 hours apart. So, how do you explain to the patient? We ask them to take it on a Monday or Thursday, or Tuesday and Friday, or Wednesday and Saturday. So, this is how we usually recommend the patient fluconazole so that they don't forget taking that drug. What about vulvovaginal candidiasis in pregnancy? We only give topical azoles for 7 days. We do not give fluconazole, as contraindicated in pregnancy. Patients living with HIV, treatment is same as non-PL-HIV. Partner treatment is not required. Follow-up is also not required. Completion of treatment is itself considered as a cure of this problem. In cases of complicated VVC, we might have to offer the patient vaginal cultures to understand if any of the non-C. albicans is causing these diseases and causing a recurrence. What about recurrent VVC? 7 to 14 days of topical therapy or oral fluconazole every 3rd day for a total of 3 doses here, followed by oral fluconazole weekly for 6 months. This is called as a maintenance regimen, and which is very, very important. Genital tract ulcers. Now, these were all about the discharges where we covered bacterial vaginosis, trichomoniasis and vulvovaginal candidiasis. Now, moving on to genital ulcers, which can be the second presenting complaint of any of the patient. So, we have the following under this heading. One is herpes, second is syphilis, third is chancroid, fourth lymphogranuloma venereum and granuloma inguinale. So, these are the characteristics of these ulcers. HSV, which is herpes simplex, causes multiple painful vesicular ulcerative lesions. If you see scattered multiple small ulcers, this is HSV. Syphilis is a painless self-limiting ulcer. Lymph node may or may not be present. Chancroid is a multiple painful punched out ulcer with undermined border. So, how do you remember chancroid is by D is painful. or dard, painful, chancroid. This is how we usually remember. LGV is lymphogranuloma venereum, is self-limiting genital ulcer. It can cause painful unilateral lymphadenopathy. L for LGV and L for lymph nodes present. So ulcer is painful. We know chancroid LGV cause painful ulcers, but LGV comes with lymph nodes. Chancroid does not come with lymph nodes. So donovenosis, which is extremely rare to be present in our country, they cause painless beefy red ulcers. Lymph nodes are absent. These can be confused with either tubercular ulcers or they can be confused with malignancy. However, in our country, they are extremely rare. So, we usually have to biopsy at the edge of these kind of ulcers.